Thank you so very much for that introduction. So, today we are going to be talking about safety as the number one priority in caring for somebody who is living with dementia. Thank you again for having me. I appreciate all of the associations and care partners that have invited us here today. Without this huge partnership, we would not be able to take the excellent care of people living with dementia that we are able to do. So I just wanted to take a few minutes to talk about dementia before we talk about safety issues. And I think one of the more important takeaways whenever we discuss dementia is that dementia is not just memory problems. Memory problems are part of it without a doubt, but it also includes a person's inability to look after themselves. And we'll talk much more about this as we go, but thinking issues, decision making, safety issues, all of this comes with dementia. You can't just think about dementia as memory problems. Most types of dementia are progressive. Most of them will get worse over time, and nearly all of them are incurable. And the life expectancy when we're talking about dementia is so incredibly variable. It can be 6 months for some very, very rare types. Thank goodness, very, very rare types. It can be 10, 20 years for some other types. Where somebody is in their dementia journey also tells us an idea of where they're going to be at, 6 months, a year, 2 years, 5 years down the road. Again, I have a little bit of a broken record alert here, and you'll see that as a running theme as we go. But dementia is not just memory problems. Dementia is a full body syndrome that makes somebody unable to look after themselves. I think one of the more difficult concepts for us as physician, caregiver, care provider, as well as for anybody looking after somebody living with dementia, is that dementia is fundamentally damage to the brain that has occurred because of some sort of medical condition. And looking at dementia as a broad category, looking at dementia as an umbrella term, there are multiple different types of dementia, and each one looks a little different. And that's because each one has brain illness, abnormal proteins, stroke, that type of different scenario that attacks different parts of the brain and makes that dementia look different. So, as I'm sure Ivy will mention later on, Alzheimer's disease worldwide is the most common type of dementia. And this is the stereotypical short term memory loss that progresses on to long term and functional changes. And I'll talk about that again in a slide or two. Vascular dementia is dementia from strokes. These can be small and silent strokes that people don't even know that they have until they've had multiple of them. And then they have problems with their thinking and memory and safety. People with vascular dementia can have weakness. They can have swallowing problems early on in the disease. And that's because where that stroke hits can change how they present with their dementia. People with Parkinson's disease can have dementia just unfortunately from Parkinson's disease. So you can have the shaking and the walking problems plus dementia. Frontotemporal dementia is a dementia that can happen to younger people more commonly than older people. And this can have a lot of personality changes. This can have speaking issues. Willis, well, I can't think of his first name all of a sudden. See, there's my word finding. Has a primary progressive aphasia type frontotemporal dementia, so that he lost the ability to speak. Bruce Willis, thank you so much. Someone put that in there. And that also takes away that everybody can have little blips in their memory from time to time, and it's perfectly normal and not anything to worry about. There's Lewy body disease. Lewy body disease can have visual hallucinations that are profoundly vivid, and eventually, as time goes on, can develop physical symptoms that look like Parkinson's disease. There's things like normal pressure hydrocephalus, which is when people have buildup of fluid in their brain, which can sometimes be halted by draining some of that fluid. And then, unfortunately, just because you have one type of dementia doesn't mean you can't have more than one type of dementia. And I would say that we have a very, very high percentage here of people who have mixed dementia, most commonly Alzheimer's disease and vascular dementia. So everybody's dementia journey looks different. And a big part of that is because everybody can have little variations and where their dementia is attacking in their brain. Okay, here's my broken record alert. Um, if everybody at home is safe, everything is fine. Nothing has to be perfect. Nothing has to be ideal. What we want is we want the person living with dementia to be safe, and we want everybody else in the house living with the person with dementia to be safe. If you have that, everything is going great. And congratulate yourself because really, truly, you got it figured out. Okay, so I did want to just take a quick moment to talk about stages of Alzheimer's type dementia real quick. The reason I'm talking about Alzheimer's here specifically is because most people with Alzheimer's progress pretty consistently in a pretty reliable fashion. Life expectancy for somebody with dementia, as I said, varies greatly. Somebody with Alzheimer's disease from the time of an early diagnosis may be in the 7 to 10 year life expectancy. So if you kind of think about this from early stage until late stage, maybe think a decade. But again, there are people who progress fast, there are people who progress slow, so everybody's a little different. So mild short-term, I'm sorry, mild stage of Alzheimer's traditionally is short-term memory loss. And it's not the where is my keys? Why did I come to the kitchen? Where did I put my glasses? This is not remembering an entire conversation. This is not remembering not just what they had for breakfast, but did they even eat breakfast? At this stage, people are needing help with things that we call instrumental activities of daily living, such as driving, medications, cooking, housekeeping, paying bills. Moderate dementia is when people are starting to have more problems with short-term memory as well as some long-term memory. And that long-term memory can be 5 years, 10 years, 20, 30 years. It can be multiple decades of memory loss. And this is when people are needing help with some of their day-to-day activities, which we call activities of daily living. So they may be needing help taking a shower, they may be needing help getting dressed. And this isn't problems where they're not able to do like buttons because of arthritis, but actually, what is a button? How does it put together? How do you start a zipper? How does the shirt go on? This may be when people come out dressed in 3 pairs of pants and 2 shirts because they're not understanding how dressing works anymore. Severe Alzheimer's disease is when people are needing help with most, if not all, of their activities of daily living. So, this is when people are needing help bathing, dressing, going to the toilet, needing help brushing teeth, needing help brushing hair. People may need help even feeding themselves at this point. They may be eating with finger foods, or they may actually be needing to be spoon fed. And then because dementia is almost all, if not all, dementias are terminal illnesses, this is something that people pass away from. There's also end stage dementia. This is when people are bedbound or wheelchair bound. They are not getting up and walking. They may be speaking just a few words. They may be having recurrent infections. They may be having bed sores, and they're often having swallowing problems. And we'll talk quite a bit more about swallowing problems later on. Okay, so I do want to just talk about common dementia-associated changes in that can occur, unfortunately, anywhere along the line. And we're going to talk more about this kind of as we move forward. But a lot of these come back to safety issues, which is what we're here talking about today. Because if somebody is aggressive, that person is not safe. If somebody is so depressed that they're not getting out of bed, that's not safe. They're at risk for developing pressure injuries or bed sores. Are they having hallucinations that are making them unsafe? Are they paranoid that makes them unsafe? So we're going to be talking quite a bit about this as we go moving forward. So what causes behavioral changes? So I actually believe that a lot of the time what causes behavioral changes is anxiety. And it's an anxiety that's like hard to pinpoint. With a lot of the time when we think about anxiety, we think about someone saying, I feel anxious. But a person with dementia may not have the ability to say, I feel anxious. And so what it comes out as is pacing or wandering or, you know, trying to leave the house, trying to get away from whatever they are nervous about. They may be anxious to the point of agitated. And then when somebody doesn't respond in a way that is the magical settle down cue, which we'll talk more about as well, they may even get to the point of agitated to aggressive. There may be hitting, there may be kicking, there may be throwing of things, and sometimes people are doing this out of self-preservation. Sometimes they're doing it because they've lost the filter, they've lost the ability to say, this is not an appropriate way to respond to a situation like this. So, frustration is another one that very commonly causes behavioral changes. And I mean, let's be honest, any of us who are frustrated enough are not going to be at our best thinking and responding wise. And same with pain. So now you have somebody with dementia who's lost the filter that says, yes, this is an appropriate way to respond. No, this is not an appropriate way to respond, and they're frustrated and they're in pain and they're anxious, or maybe they're fatigued. That's going to come out as potentially a behavioral change. And that's often when we notice safety issues, because when we're not thinking at our best, we may start doing things that are unsafe. Other things that I think are worthwhile just to mention, changes in routine. So anytime somebody with dementia doesn't have their usual routine to fall back on, they're using their long-term memory as opposed to their short-term memory to make life manageable, to make life more understandable to them. They may become anxious, and that can cause some behavioral changes. Any of us, when we feel like we are out of control and we don't understand what's going on, are more likely to not be at our best. People who have dementia very easily can be over or understimulated, and that can cause behavioral changes. And again, we'll talk more about communication here in just a moment, but poor communication to somebody who's living with dementia can be very difficult for them to communicate that they're not understanding what's going on. And so that may be read back as agitation or even aggression. And again, immediately becomes a safety issue. And then urine and bowel needs. I always tell people constipation is a problem from tip of the head to tip of the toes. It affects absolutely everything in a person's body. It can, without a doubt, cause issues with confusion and appetite and upset stomach and all of that. And then urine issues. And we commonly think about urine issues like urinary tract infection. Urinary tract infection can cause behavioral changes that are unusual for that person if they have dementia and this new urinary tract infection. That being said, urinary retention, so the inability to actually be able to urinate, can cause people to become agitated. That is very uncomfortable for everybody at every age. But if you can't vocalize that that's what's going on, you may have more problems with agitation, aggression, anxiety, all of that. Okay. Oh, sorry. Okay. So I did want to talk quite a bit about communication, because this is hands down the key to making life smoother for an entire household. So I always think about dementia care as not just care for the person living with dementia, but taking care of everybody who's involved. So I have to think about the health of the house, the safety of the house. So somebody with dementia, as I was mentioning, may not be able to communicate their wants, their needs, their worries, their pains. And so the person looking after them may be guessing, what is the cause? What is the underlying issue that's making this person I'm caring for pace up and down inside the house? What is the underlying issue that's making this person sit in bed all day long and develop pressure injuries? Both of which are safety issues, because as we'll talk more about, someone who's pacing is going to be more likely to fall. Someone who's in bed all day is going to be more likely to develop pressure injuries. These are not just health issues, these are safety issues. So, if somebody is not understanding what is being said, sometimes we have to be a little bit more creative about showing somebody something. Maybe we just need to let that person calm down. Maybe we need to distract them and get them interested in something else. And we'll talk more about that as well. So that maybe that gives us a little bit of time to figure out what they were trying to tell us. Or maybe it was a worry they had in their head. And if we distract them, that's the end of the worry. And we don't need to figure out what's going on because we solved the issue just by letting them settle down. If the person you're taking care of is safe and you're safe, everything's okay. It's fine. Nothing needs to be perfect. Safety is our number one priority. So I always tell people when they're in the clinic and I'm looking after them, safety is my number one priority, and happiness and healthiness comes right underneath that. Because no one who is unsafe is going to be healthy. And most caregivers, and then hence the person they're looking after who has dementia, is going to be safe in a situation where people are unhealthy and unhappy. So if everybody's safe, everything is fine. You absolutely don't need to correct somebody if they are unsafe. There is a great article about, you don't have to tell somebody, and you'll see this on the Alzheimer's Association website. You'll see this on any sort of Alzheimer's or any sort of dementia resource. But you don't have to correct somebody. You don't have to argue with somebody. You can let it go when they get it wrong. Chances are, if you try to correct somebody who believes something fully, you're just going to escalate the situation. You're just going to make things worse. Not because you want to make things worse, but because it's a kind of human nature to try to get somebody to see to see the true situation. But you don't have to tell somebody with dementia the whole truth. You can do what we call therapeutic fibbing or therapeutic lying, which is where we actually say, you don't have to give the right answer. It's all right. So one of the things, or two of the things I hear very commonly from people are, the person I take care of wants to go home, but they're in their own home. They're in their own home that they've lived in for 30 years. That person has lost so much of their memory that they are only remembering at this point a house from probably youth or maybe 20s or 30s. So when they say they are not home, they are thinking of a home from decades ago. And the answer that goes best is the right answer. So if the right answer is we're not home because we are staying in this house for a short while because we are tenting the other house. I'm going to go into the kitchen and I'm going to make a snack. Would you like to come with me? That's absolutely the right way to do things. If the right answer is, this is our house. See, that's where you painted that painting and put it up on the wall. And they go, okay, that sounds right. That's the right answer. It's not a one size fits all. It's the right answer for that person at that point in time. And what may work well once may not work well the other time. What we know works really well for almost everybody a lot of the time is getting somebody out of the environment where they are stuck thinking about something. So if somebody is stuck in the living room thinking about how they want to go home, they want to go home, they want to go home, then get them in the car and go run to McDonald's and get milkshakes. Again, when you're in your 80s and 90s, the rules of what you're allowed to eat change. So that's a good time to go get milkshakes from McDonald's. Get somebody out of the physical location where they're stuck, get somebody kind of out of the mental location where they're stuck, and that will really help redirect. The other one that the therapeutic lying or therapeutic fibbing works really well for is when people say something like, where is my mom? I want to see my mom. Is my mom okay? That's a great answer to say, I'm not exactly sure where she's at right now, but she's fine. She's doing okay. There's nothing you need to worry about. You do not need to tell that person over and over again that their loved one, that their mom, their dad, their husband, their wife, whoever that is, has passed away. Sometimes that's an okay answer because it kind of gets digested all right. Sometimes when that happens, the person is going to go through grieving all over again. And nobody wants to see the person they're taking care of go through grieving all over again. So it's all right to just say, your mom is fine. I haven't heard from her today. And that's an honest answer. I haven't heard from her today, but she's fine. And leave it at that. And that's a good time to change the subject and kind of move forward. Okay, so I've mentioned a lot of these things, but one of the most important things is acknowledgement. We need to acknowledge what they're feeling. Nobody wants to be dismissed. I don't care if you're 2, I don't care if you're 102 plus. Everybody wants their thoughts and their feelings acknowledged. You may not understand their thoughts or their feelings, but we still need to acknowledge it. I understand you're worried about your mom. I haven't heard from her today, but she's doing just fine. Again, redirection, distraction. These are my favorite things. Getting somebody out of wherever they are stuck, getting them, honestly, a snack, getting them out to do something else is hands down the best way. I used to take care of a patient who has since passed away, and his daughter was a master at this. Every time he would start getting agitated, she would dig into the back of the wheelchair and pull out a snack, pull out a peanut butter and jelly sandwich. He would sit down in the visit, get calm again. He'd start getting agitated. She'd pull out an applesauce packet and give it to him. I mean, just absolutely spectacular. She knew exactly what would settle him down. It was beautiful. I have reorientation with a question mark there because this is the bringing people to real reality as opposed to living in their own reality. What we know is true and now may not be the kindest answer for them. Telling a widow that her husband has passed away every time she asks about him may not be the kindest and most loving way to take care of that bit of anxiety. Maybe saying, and I've seen families do this where, a husband went into the hospital and the wife is asking how he's doing. And the answer is always, he's doing fine. He's in the hospital. And he may have passed away 6 months ago or a year ago or 2 years ago. And that's okay because she just needs to be heard. She just needs to be acknowledged. She just needs to know there's nothing she needs to worry about right now. So you don't have to reorient. I tell people that somebody who believes something fully and completely are very they believe it. They believe it with all their heart and they're very set on that thought. And so it's okay to not try to take them away from what they believe because you're never going to convince that person. So it's okay to join them where they are at. Again, just let them know that you hear them and that you're reassuring of whatever their worry is. So meal and snack, we talked about that. Again, getting somebody out either to the kitchen or getting in the car and going for a car ride. Sleep, sometimes maybe a little cat nap is just what somebody needs. I will tell you real quick, and this is something that can be a safety issue and can be a wandering issue, and we'll talk more about wandering in a minute. But people with dementia who wake up from a dream cannot tell the difference between real life and a dream. So until they are fully awake, it may take a little while for them to figure out where they are. Are they in a dream where they need to get in the car and go pick somebody up? And that's where the safety issue is I've had people wake up from naps or in the morning saying, I got to go to work, or, my cousin's at the bus stop, I got to go get them. And it is an uphill battle to prevent that person from getting in the car and driving away. And that's something that you do need to actually find a way to prevent them from walking down to the bus stop or driving to go to the bus stop to pick somebody up. That's a safety issue that is worth an argument if it comes to that. But ideally, you can say, you know what? While you were asleep, they called and said that they're running late. We don't need to pick them up at the bus stop for 2 more hours. Or while you were asleep, your boss called and said that everybody's getting a late start today. Why don't you come have breakfast with me? But we need, for safety's sake, to make sure that that person doesn't follow through with whatever they've been dreaming about and thinking that they need to take care of. When we're looking at behavioral changes, other things to think about, pain control. Again, pain will make somebody do things that are not necessarily safe. Pet therapy. Pet therapy, and this can just be even, a dog in the house or a cat in the house can be very calming for people. Or now we have all of these like animatronic dogs and cats that people can have at home where you don't even need to worry about having a live animal that can be very calming for anybody, anxiety, depression, agitation, any of those things. I think we talked a bit about bathroom, but definitely getting somebody on a bathroom schedule both for urine and for bowel movements can help settle behavioral changes as well as help with safety issues. One of the big issues that we hear all the time is, mom fell on the way to the bathroom because she was rushing and she forgot her walker and she fell. So if you get somebody going to the bathroom on a more regular basis, if you prevent somebody from having diarrhea or constipation, then you're going to have less of those falls on the way to the bathroom because you're not going to have so much rushing. Or maybe the solution is actually a commode on the side of the bed, or maybe it's a urinal on the side of the bed so that mom or dad doesn't have to go rush. So sometimes there are simple things that we can do that can help keep a person safer, less anxious, less agitated, and then also hopefully decrease the risk of things like agitation or even aggression. So I do want to talk about non-memory symptoms of dementia because so much safety issues come from this. So we talked about anxiety, wandering, where is my mom? I'm going to go walk down the street and look for my mom. Or maybe they're just pacing back and forth because they're anxious. Both of these are huge safety issues. Ivy, I'm sure we'll be talking more about wandering issues and wandering safety, but this is when we need to think about an ID on that person at all times. And that can be a medical alert bracelet. That can be quite literally a dog tag. I tell people if you're trying to save money or on a limited budget, go to Petco, go to the pet store and get a dog tag and say, like my name is, in case of emergency, contact, and then a phone number on there and say, maybe has dementia or has memory problems or something on there. And that can be tied to a person's shoe. It can be put in somebody's wallet. It can be safety pinned on the clothes. And it's dirt cheap and you can get it same day. It's very simple. Um, Trackers are a very good idea. So Apple AirTag, Tiles, they make lots of GPS devices. They're GPS devices that can go in shoes, GPS devices people wear as a watch. If somebody is well enough that they're using a phone, almost all phones nowadays have GPS tracking in there. Depression can cause issues with poor appetite and inactivity. There's kind of two extremes for depression where people eat a lot and people don't eat much at all. For seniors, it's usually people lose appetite and they lose a desire to go outside and do anything or even do anything inside the house. This is a huge safety issue because if you're not eating and you're not exercising and you're spending all day in bed or the recliner or the couch, you are much, much more likely to become frail, and frailty increases risk of falls. So this is something that we need to address as part of the care of the whole person who is living with dementia. I do want to just take a quick moment to talk about apathy. I know I'm running low on time, so I'm going to just kind of go through this quickly. Apathy is different from depression. Apathy is when people are perfectly happy doing nothing, sitting in their chair all day, just, watching TV. And again, this can increase risk of frailty and it will also cause dementia to progress faster because of the lack of exercise, because of the lack of socialization. And then incontinence. So incontinence can be everything from incontinence of urine and bowel, which can increase risk of urinary tract infections, which can increase risk of pressure injuries or bed sores. People who don't understand that they're being cleaned because they're incontinent can refuse to be cleaned. And that can cause a lot of safety issues. That can cause issues where they're hitting and punching and kicking somebody who's trying to clean them. So, all of these things that we think about that's related to dementia that has nothing to do with memory cause both behavioral changes and unfortunately put you at high risk of having safety concerns. I have a whole slide here on falls because I really wanted to take a bit of a time discussing why this is so incredibly important when you have somebody living with dementia. Basically, everybody with dementia is at a high risk for falls. And it's because of all of these non-memory issues, in addition to the memory issues. If you don't remember that your balance is poor, you are going to climb a ladder and go up and clean your gutters, or you're going to go pick the mangoes because you don't remember that it's not safe. So it affects your balance. That's a brain change that comes with dementia. Coordination, visual spatial capabilities. So where is my foot on the ladder? Where is my hand in regard to where that mango's at? You can have vision changes associated with dementia. That can be hallucinations. That can be because you've had a stroke that causes your dementia, that causes you to have vision issues. And people with dementia, just by definition, don't make safe decisions. So again, they are more likely to go climb up on a retaining wall and try to grab something that's up there. They are more likely to so I should actually back up. So as we as we get older, we have a tendency to not realize our age. We have a tendency to do things that we probably shouldn't as we get older because our balance generally isn't quite as good. Our strength isn't quite as good as we get older. So even if your memory is perfectly fine and you don't have dementias, you may still be making what probably is an unsafe decision about climbing and heights and ladders and that kind of thing. And then when you add into that a person who simply cannot make safe decisions, there's going to be more issues with falls. So if somebody falls, the first thing you really should do, I mean, if it's not an emergency situation, and any emergency situation is a 911, you go straight to the hospital. But if it's not an emergency situation, you need to see your doctor. You need to see your primary care nurse practitioner. You need to have a checkup and make sure that everything is okay. Blood pressure is okay. That's a huge issue. Hydration is okay. Looking through medications, all of that to make sure that everything can be made as safe as possible to keep somebody from reducing their fall risk. I cannot say enough good things about physical therapy and occupational therapy. They are miracle workers for reducing fall risk because so many times people are losing their balance because of brain changes. And we can often make balance better, not always, but often. And we can always make somebody's strength better. So we can always help somebody get stronger to the point where they're going to be less likely to fall. And then we have occupational therapy who also will help make a house, make an activity safer. And these people can come to the house and do home safety evaluations and say, maybe you need grab bars, maybe you need a bedside commode, maybe you need a slide in shower chair. Vision checks are really important because if somebody doesn't have good depth perception or a good ability to detect changes in colors, maybe cataracts, maybe glaucoma, maybe macular degeneration, they're going to be more likely to fall. And then the takeaway in the end is supervision. You need a safety net, maybe a life alert system, one of those I've fallen and I can't, I'm fallen and I can't get up buttons. An Apple Watch has automatic fall detection in it. Most of the life alert symptoms, without a doubt, have automatic fall detection on them as well. And then nowadays in technology, we have a lot of webcams. And truthfully, I think it's a great idea for somebody to have a webcam in the house so that you can see what's happening if somebody is actually safe enough to live at home. Okay, I'm going to wrap up. I know I'm running low on time. So other things that I do want to discuss, especially safety wise, we've talked about wandering, but very quickly. The other thing that I haven't discussed is door locks and unusual door locks. So a door lock that either goes up above at the top of the door or real down low at the bottom of the door. You can get one through the Alzheimer store that's absolutely wonderful. That is a flip lock. You basically, it's like, it kind of reminds you of a lock inside a hotel room, but you put it up high and you lock it, and the door cannot be opened. And a person with dementia doesn't have the problem-solving capability to look up above. And so the good news is that they are much less likely to open a door and wander. Okay. Dysphagia is swallowing problems. This increases the risk of things like aspiration pneumonia and also can cause discomfort for people where they're less likely to want to eat or drink. What we recommend for this is to see a speech and swallow therapist so we can determine what's causing it, if exercises are beneficial, if an altered diet like chopped solids or thickened liquids actually makes it easier for a person to swallow safely. It is worthwhile to know that altered diets, such as thickened liquids, do not actually, unfortunately, decrease the risk of things like aspiration pneumonia. It does definitely help a person swallow in a more comfortable manner. So it becomes extremely important to have that swallow evaluation because we want them to swallow easily in a way that's much more comfortable without the coughing and choking and all of the distress that comes from that. One very quick line about tube feeding. When somebody has dementia and they have swallowing issues, tube feeding does not make a person live longer. It does not make a person more comfortable. And it also does not decrease the risk of aspiration pneumonia. So pneumonia from things going down to the into the lungs. I'm not going to spend any time talking about driving. I believe driving is going to be discussed at another one of these down the road. But I will say that executive function is a very big issue. This is higher level problem solving. This is when people are more likely to develop risky behaviors driving or be more likely to be scammed out of finances. This is when people are having more problems with medications and falls because their problem solving is becoming much and much more difficult as time goes on. Okay, so safety. When does somebody need help? When there are health and safety issues, and they need to be readdressed regularly. So when my patients come into the clinic, I'm always asking, have there been any falls? Has there been any change in that person's functional status? Are they still showering on their own? Are they still getting dressed on their own? Are they now needing help with things like medications? Has somebody put their name, has a son, a daughter, someone else in the family that they trust and have chosen, put their name on their checking account so the finances can be overlooked just to make sure that something like scams aren't happening. Early on in the disease, a lot of these, and again, these are often instrumental activities of daily living, the high level day-to-day activities can be done with just an occasional visit. So maybe once a week, somebody's family member or a friend comes over and fills their pillbox. That's all they need. Maybe they just need help with transportation. As the dementia worsens, they are going to need more and more help with complicated day-to-day activities and then simple day-to-day activities. And eventually, everybody is going to need 24/7 care. And you need to have a health and safety plan that is very specific to that person because it absolutely changes based on what is needed for that person to keep themselves safe. So when when does the person caring for somebody living with dementia ask for help? Often behavioral issues, incontinence issues, sleep issues. I just want to, again, broken record here. If everybody is safe, everything is perfectly fine. You are doing a wonderful job. Keep it going. You need to take care of yourself, or you're never going to be able to take care of somebody that you love, somebody that you provide care for, and you cannot do it yourself. You absolutely need a team of care. It needs to be more than one person as the illness progresses. And again, I know I'm running out of time here, but I do want to take a very quick moment to say that you need to be really patient with yourself as a caregiver to someone living with dementia. And when things go poorly, you need to forgive yourself. You're doing a great job. You're doing your best. That's all any of us can do. And if everybody's safe, everything is okay. So just a very quick moment to talk about safety, because what safety looks like for a different person is different based on what they need, what their finances are, what the family situation is, what the non-family caregiver situation is, because it can be provided in home or away from home. And it's not the same for everybody. Now, I'm not going to go through details here, but families provide care in addition to someone attending something like an adult daycare and adult day health. Families provide care along with non-family caregivers, paid caregivers, non-paid caregivers, volunteers, and it can be a mix of all of these things. Someone could be moved out of their home to a more supervised living situation like an assisted living or a memory care or a care home or a foster home or a nursing home. So, what works well for one person does not necessarily mean it's going to work well for someone else. You got to look at the health and the safety of everybody. If you have a 98-year-old person living with dementia taken care of by a 98-year-old spouse, that looks completely different than somebody who's living in a multi-generational home where you've got kids and grandkids and spouses and in-laws, and that might not be somebody you need to hire in help because you have so many people in that house, or maybe that person's still going to adult day health. It's very individualized, and it also unfortunately comes down to finances in part. But again, broken record alert. If everybody is safe, everything is fine. You are doing a great job. Just keep taking it day by day, asking for help. If you need help, accept help. Reach out to your care team, social workers, nurse practitioners, nurses, your physicians, all of us. We are here for you. And thank you so much. I know I've run up a little over into Ivy's time, so I apologize to Ivy, and she's going to go through a lot more information. Thank you all so much for letting me be part of this today.
Mahalo, Dr. Barry. And thank you for providing, just that helpful context and sharing such kind and compassionate strategies and insights. I thought that was really helpful. Good morning, everyone, and thank you so much for the opportunity to contribute to this conversation. As mentioned, my name is Ivy Castellanos, and I'm with the Alzheimer's Association. And today I will sort of piggyback on some of the information and strategies Dr. Barry shared, and I'll double click on a couple of things, falls for a quick minute and wandering. And I'm also really excited to talk about how the Alzheimer's Association can provide resources and support. And next slide, please. So a little bit about who we are. The Alzheimer's Association, we've been in the local community since 1982, so for almost 4 decades, and our mission is threefold. So you can see here, we're focused on accelerating research, driving risk reduction and early detection, and maximizing care and support. So fun fact, we are an organization that was actually started by a group of family caregivers. And locally, we are a statewide team of about 8 staff and an amazing group of volunteers who are committed to this vision of a world without Alzheimer's and all other dementia. So sometimes folks will ask us, oh, my family member is dealing with frontal temporal, right? Can we still access services, or how does that work? Yes, we are happy to support anyone dealing with any form of dementia. Next slide, please. So Dr. Barry talked about this care team, right? And we really see ourselves as an extension of a person's care team right alongside the provider, specialists, a team of social workers, OT, PT, family, friends, faith group, right? It's really critical to build this care team. And so we're here to supplement that and provide credible information, resources, and to really, create a space for connection and community through our programs. We have a 24-hour helpline. That's a great resource. We have staff that can be contacted anytime, day or night. We have a whole host of education, support, and resources. Everything that we offer is free of charge, and I'll dive into some of these programs and services in just a moment. Next slide, please. So to kind of revisit what Dr. Berry shared, safety is critical, right? Because dementia changes everything, how a person thinks, remembers, how they move, and really kind of interpret the world. So if we kind of glance through some of these bullets, lapses in memory can lead to, harm or medical emergencies like taking the wrong medications or forgetting to turn off the stove. Some of the changes in judgment and decision making, that takes place can make a person more susceptible to things like accidents or exploitation. Dr. Berry talked about scams and fraud. Um, as language and comprehension decline, a person might have trouble expressing pain or communicating those basic needs, like having to go to the bathroom, or maybe they're uncomfortable because their pants are too tight. Right. So in terms of behaviors, this can sometimes delay care and it can potentially worsen outcomes. In terms of mobility and sleep, dementia often coexists with balance or coordination problems. I think we lost our slides for a moment, but let me just pull this up here. And I think everyone has access to the slide deck, so we can, follow along there. But with, kind of balance, coordination issues, and confusion, this can really lead to, the falls and injuries that we've been talking about. And as Dr. Berry shared, falls are a major reason people with dementia require hospitalization or long-term care. And then at night, some people experience sundowning or, disorientation, which can increase the risk of injury while caregivers are asleep. So it can make it a challenge for both the person with dementia as well as a caregiver to get restful sleep. And when we're trying to talk about self-care, that can make it really difficult. Changes in perception can make kind of everyday things and objects seem threatening or confusing. For example, a person might see a shadow and believe perhaps that someone is trying to peer into the house or break in. And so as caregivers, even if it's a distortion or a hallucination, it's experienced as a real event, and it can lead to things like panic or aggression or that unsafe behavior that we're really trying to mitigate. And last, in terms of dignity and quality of life, good safety practices, here we go. Let's see if we can maybe scroll down to why safety first. So 1, 2, 3, slide 3. So why safety first? And so I think, kind of the main takeaway is these, safety practices and being mindful of putting safety first. That can really help our loved ones stay independent longer. They can participate more fully in daily activities. They can maintain their confidence and that degree of autonomy and avoid, just the unnecessary stress and potential for hospitalization. So safety isn't just about protection, but it's really about supporting their well-being and quality of life. So next slide, please. If we can go perfect to fall prevention strategies. So I think Dr. Barry did such a great job going over, kind of the consequences of falls, right? And we know that falls can increase confusion, they can lead to complications and accelerate cognitive and functional decline. So our job as caregivers is to try wherever we can to create a safe and kind of clutter-free environment. So we have some tips listed here, clear hazards, improve lighting, maybe working with OT and PT to look at bathroom safety and setting up the home. For any modifications that might be helpful, paying attention to footwear, even, compression socks, right? Making sure that they're grippy and not slippery. And I think an area that we can double click on is physical activity. So engaging in regular exercise with a particular focus on lower body strength and balance, right? And so for anyone in the early stage or for family caregivers, and we're thinking about prevention, doing what we can as early as possible to incorporate weight-bearing exercises to build kind of that muscle tissue and strength, so we can avoid things like osteoporosis. And medication review, as Dr. Berry talked about, really consulting with a provider to take a look at any medications that might cause dizziness or drowsiness or things that might make a person more prone to falls. Next slide, please. And some additional tips for caregivers. Thinking about the nighttime routine or that transition from sleep or night to morning, right? Taking a moment maybe to work with our loved one to encourage that pause before getting up from the bed to go to the bathroom or to start that day. Supervision, taking a look at and being really careful to watch out for, changes in gait or balance. Keeping items that a person needs to access within easy reach and in kind of the same place so they know where to reach for those items. And we also have a home safety checklist that might be helpful. So I believe we'll put that in the chat for folks to take a look at. Another tip for caregivers is if there is a fall in the home, you always have the option to call the fire department. So the fire department is wonderful about coming out to the home and helping, lift someone that's fallen or helping just to make sure that the caregiver and the care recipient is safe. There's no kind of charge or billing for that. But I know that they've been really helpful for families in helping get the loved ones off the floor after a fall, making sure they're okay. Next slide, please. Okay, so wandering. We know that wandering is very common. We know that about 6 in 10 people will wander, and it can be really stressful and a scary situation. Sometimes there are, warning signs. We kind of can sense that someone might be prone to wander, but frankly, sometimes there's no indication of this whatsoever. So here's some tips to consider. Thinking about a person's day and how it's structured, just making sure that they are engaged and stimulated in meaningful activities throughout the day to reduce, that boredom and agitation later in the day. Sometimes we know that there might be a time of day that a person is more likely to wander. So for example, if someone was, a school teacher, right, and would get ready to leave for work at 6:30 every morning out the door. If we are seeing that this person sort of gets restless or is wanting to get out the door at that time, that might be a good opportunity to do things like take a walk or engage in some light physical activity. Ensuring, as Dr. Barry mentioned, that all basic needs are met, and at night, reducing liquids a couple of hours before bedtime can really help ensure and minimize the number of bathroom trips during the night. And wherever we can, involving the person in daily activities, enlisting their help, making them feel as if they're, contributing and getting them involved in just daily things like folding the laundry, setting the table, folding napkins, things like that. And then reassuring the person if we notice that they are feeling lost or maybe need to be grounded. Sometimes it's by touch, sometimes it's a reassuring tone of voice, and sometimes it's just our presence. So, a couple of things to consider. Next slide, please. And if the person is still able to drive, as Dr. Barry mentioned, a GPS device, various trackers. And if they're no longer driving, something that might be helpful is to remove their car keys. Sometimes those visual cues are triggers, right? They may have forgotten that they stopped driving. So out of sight, out of mind sometimes. We want to avoid just overcrowded places that are confusing or disorienting or really overstimulating, like the mall. And then last, it can be difficult, right, to introduce brand new surroundings, or it can be difficult to navigate environments that are outside of the norm. So really being mindful of a person's response to these kind of new surroundings, and providing that support and monitoring in those types of situations. Um, when we're thinking about wandering and preventing wandering, many of the same strategies apply for falls and home safety in general. And it's a huge responsibility, right, to ensure someone else's safety, and sometimes it can be a little overwhelming. But being, proactive and setting aside some time to come up with a plan and prepare can really help. So wherever possible, having a plan in place beforehand is helpful. So in the event of an emergency, we know exactly what to do. We can consider enrolling our loved one with dementia in a wandering response service. The Alzheimer's Association used to participate in the Medical Alert and Safe Return program, which unfortunately we're no longer a part of that. But Medical Alert still has a program. I believe it's called Safe and Found. So if you Google that, they have a program. It's a subscription along with a piece of identifying jewelry that a person can wear. And last tip is it's always a good idea to keep a recent photo, of your loved one on hand in the event of an emergency, to be able to give to, the police or the authorities if an instance of wandering occurs. Next slide, please. And so, if someone does go missing and is wandering, there is a program called Silver Alert, which is similar to the Miley Amber Alert. And it's a notification system to broadcast information about missing persons. With Silver Alert, it's for kupuna age 65 and older, as well as those with developmental disabilities. Next slide, please. So this Silver Alert program was actually signed into law in 2024, but it's not yet operational, unfortunately. So as I understand it, it sits with the Department of Law Enforcement, and it's awaiting a launch timeline from the county police department. So there's some logistics that are trying to be ironed out. But if you go to the Department of Law Enforcement website, it's law.hawaii.gov, and we can share this website. But there is on that site an intake form, and you can report an elderly or at-risk person if they go missing. So there's a form. We also link to it on our Alzheimer's Association website. But being that the program's not yet operational, I don't know where that information goes. However, what you can do at this moment in time is there is kind of this pre-registration form that you can use to register your loved one in the event of an emergency. So as part of that pre-registration, you can, upload a photo, you can provide your contact information, identifying information for your loved one. That's something proactive that we can do as we kind of await the launch of our state Silver Alert program. Next slide, please. And in the meantime, these are photos of some of our local kupuna that have gone missing. The first gentleman on the left is William Burr, and he was reported missing back in October of 2023. He wandered away from his home. After about a month of searching, he was found deceased on the side of a highway. He had a fall. And his brother, Joseph Burr, flew down here to Hawaii and advocated for the passing of this Silver Alert bill in 2024. The gentleman in the middle, Mr. Frank Pangilinan, he went missing back in May of 2023 after being last seen in Kapolei, and he's still missing. He's not been found. Kunzang Yutok on the right, she was reportedly last seen on November 20th, 2023 in Kailua Kona, and she has also not been found. So it's a heavy topic. It's really hard to think about, and we really empathize with these families, and we're really trying to urge the authorities to prioritize the launch of this Silver Alert. Next slide, please. Okay, so to switch gears a little bit, I do want to share about some of the programs and services that are available through the Alzheimer's Association and how we can help. We have ongoing education programs. These are, offered in the community as well as on site by request. So sometimes employer groups invite us to come in and talk about, the warning signs of Alzheimer's and dementia. Or we might have a kupuna group that invites us to come in to talk about communication and behaviors. Right? So all of our educational classes are listed online at the web address there. We also offer things virtually. We do live webinars. We have a monthly lunch and learn education program. We also have on-demand education. So we have this learning management system where all of our content is posted and can be accessed anytime, day or night. So sometimes, especially if it's a, say working caregiver who's not able to break away during, the day or when we're offering programs otherwise, they can access any of our education programs, at 2 o'clock in the morning if they want. We hold caregiver support groups in many of our local neighborhoods. This is statewide. We just launched 2 new groups here on Oahu, one in Kaneohe and one in Mililani. So we have the full listing of all of our caregiver support groups on our website at aoz.org/Hawaii/support. We also offer early stage programs, so programs specifically for individuals living with dementia. We do some social engagement programs as well. So we are launching a new kind of Al's Cafe. It's just kind of coffee and talk story. And so we hope to be able to do that on an ongoing basis every month for people living with the disease, for caregivers, for friends. Just an opportunity for folks to come together and connect. We also offer something called care consultation or supportive counseling sessions. So that's an opportunity for folks to connect with a staff person and really sort of map out, a plan and think about next steps. And it's our chance to take a look at a person's situation and maybe plug them into other community resources that might be helpful. We have a whole bunch of online tools and resources. And as I mentioned, an education center where we have these on-demand programs. And we also have a new app. This app is for people living with the disease as well as family caregivers. It's called My ALZ Journey. So you can download that, through any app store. And we've been getting really good feedback. There's some really cool stuff on that app there. And, our contact information is listed at the bottom, our website, our local office number. We have a general email inbox, and then, of course, our 24-hour helpline. Next slide, please. And, in addition to Catholic Charities and Queens and Haliku'ike, they have their upcoming conference on April 9th. We also have two conferences that we would like to invite you to attend. It's an annual caregiver conference called Ola na Lima Malama. We are going to be holding our Oahu event on Friday, March 27th at the Blaisdell. And the very next day will be on Kauai at the Fine Arts Center. But our keynote speaker this year is Adria Thompson. And for our Oahu conference, we're really excited that we have Dorothy Colby joining us again. So it'll be, just a great day of learning and connection. We have an afternoon panel on affording care in Hawaii. So we're really excited about this year's topics and lineup. So please feel free to register. There's a link and a QR code there. Next slide, please. And our March Lunch and Learn webinar is on the brain health recipe. So we have one of our colleagues, Claire Day, who's going to share kind of the study findings from the US Pointer study and talk about, brain health and what the research has shown in terms of lifestyle modification and risk reduction. So we're really excited about that. We hope you'll join us. And next slide, please. That kind of concludes my portion of the sharing. I know everyone's anxious to get their questions answered, but I do want to just highlight some additional resources and links here. Please feel free to browse through these resources. We have Catholic Charities, some tools and resources there, and some additional links that are listed. So without further ado, I'm going to hand things back. And thank you very much.
Well, thank you to you both. That was just full of wonderful information. Thank you. We'll go into Q&A shortly. I just want to say to the person who chatted in about wanting meaningful activities and tips, for your March 27th conference, I think Dorothy's going to be covering activities. Is that correct? So that person that chatted in might want to attend that conference. Is it available via Zoom, the conference as well, on the 27th?
So we will be recording the conference, and so we will be able to share the recording post-event.
That's great. That's great. Thank you. Okay, then. I will thank you both for staying on camera. I'm going to go off of camera and read the questions that came in. And if they come up, either one of you can answer. It's up to you. The first question is how to handle decluttering when they don't want to let go of anything, which makes environment unsafe, like the cluttered floor, etc.
Ivy, did you wanna? You look
Yeah.
like you.
Oh,
Oh,
no,
okay.
go ahead. Go ahead, Dr.
Okay.
Perry.
So, okay, so this is one of those very difficult situations because, two things may be going on. It may be somebody who has always been a clutterer their whole life. There is a bit of that anxiety hoarding type situation, or maybe it's because they've had brain changes because of their dementia that they're now starting to have all of this clutter issue. So it really is a question in my mind of, is it a safety issue? If it is not a safety issue, it is not worth anybody's stress to make an argument about it. Obviously, it can very quickly be a safety issue with fall hazards and fire hazards and such. So if that's the case, probably the best things in my experience have been, trying to get the person who has dementia, who has the clutter, involved in just tiny little bits, very manageable, not we're going to clean a room, we're going to clean half of this table. Or may we discuss this one stack of papers and just do it in just tiny little piecemeals because somebody with dementia is going to feel overwhelmed very rapidly. And so you don't want to attack a room or the house. You may want to partner with that person's physician or nurse practitioner about an anti-anxiety medication. There are medications that work well for people who are likely to hoard. So this may be a situation where you may want to get them in to see their physician or nurse practitioner, get started on an anti-anxiety medication, and then 6 weeks, 8 weeks, 3 months down the road, when you've hit the right medication at the right dose, then start addressing the decluttering. If it is a really, really big issue, I'm going to be really honest with you. The answer might be having one family member take that person out of the house, another person come into the house and clean up again, just a little bit, just a little less than noticeable amount, and do this regularly until the house is safe. I know, Ivy, if you have any other thoughts. It is a very difficult situation, though.
Yes, it is. And that's such good insight, Dr. Barry. And I know that, this is not in the instance of a very serious case of hoarding, but sometimes it is reminiscing about those objects or what they mean and the stories behind them that can be really powerful and therapeutic, right? And sometimes it's the realization of, oh, it's that memory or it's that story, less so the object. So if it's a small clutter, kind of going through those things with that exercise can be helpful and fun. And then it kind of releases some of the attachment and power of the object itself. So just some food for thought.
Thank you. Okay, we have about, what is it, 18? We have, 12 minutes left. If both of you can stay a little later, let's try to rush through these questions. But let's see. The next one is how to handle when the person refuses to go to the doctor appointments, doesn't want help, sometimes not taking meds, etc.
What I've seen works really well with my patients is that families get the person living with dementia in the car to go out to eat or go to the market or something, and then they happen to just stop by the doctor's office and say, "Oh, I made an appointment. You're due. Let's go on in." Have I seen people in the parking garage in their car because they refuse to get out? Absolutely. So I think if it really comes to that, that is something that can absolutely be a one-time type situation. Obviously, we don't want to have all the doctor's visits in the parking garage in the car. Some people who have significant enough behavioral changes with dementia won't ever come to the doctor. And if that's the case, then you might want to actually reach out to see if they would benefit from a house call physician coming out to see them. That might be a situation where if they really won't come to their checkups, we have somebody come see them there. I've had a few people who refuse to take medicines, refuse to go see the doctor, and we've all kind of come to an agreement that at this point, because they're not acutely unsafe, they're not really unhealthy, we're just going to let them make that decision and be aware that something bad may happen. And in that situation, we just continue to do our best. I do regular check-ins with the family, even without necessarily seeing the patient, so telephone call type check-ins. Other options, beautifully, telehealth. We can do telehealth visits. Have I had visits where the person in the background says, I'm not going to talk to you, I'm fine, I don't need anything, and then the rest of the visit is with the family? Absolutely. So there's a lot of creative solutions. Same with medications. My kind of one line, I'm guessing Ivy probably has a lot of medication suggestions. My one line about medications is when you give somebody medications, say it's time for your medications, please take these, and then see if they do. If they do, that's great. If they don't, take the medications with you, come back 5, 10, 30 minutes later and say it's time for your medications. Same smile on your face like you've never done it before. Try to get them to take their medications and do this as often as it takes until either you've lost the ability to keep a smile on your face while you're doing it, or until they take the medications. Some medications, sometimes you just have to decide, does it have to be taken that day? It's probably okay. Occasionally, if they miss without knowing what somebody takes. The other options, and I know I just had one line and I now apparently I'm lying about that. The other options are sometimes people listen to one family member and not another family member. Sometimes people listen to grandkids. Whenever you can get grandkids to get somebody to do something, that almost always goes well. But ask for help. If it's not you that person listens to, see if somebody else is around.
There are two questions that came that are very similar and related. We'll do them at the same time. At times, it appears that manipulating communication or not addressing issues is a form of enablement. A person who doesn't want to or can't acknowledge memory issue or refuses to go to the doctor is denying an opportunity for help. And the next question is trying to convince a loved one of the need to go to the doctor for diagnosis worth an argument?
Um, a really, really important part of dementia is that people with dementia have have a lack of insight into their disease. So somebody with dementia is not in denial. They truly cannot see that they have dementia. So a conversation of you need to go to the doctor to get diagnosed with something is not going to get you much of anywhere, quite honestly. For that matter, when somebody comes to the doctor and if they have anything more than just very mild illness, it doesn't add anything to the person living with dementia's life to be told over and over and over again, you have dementia, you have Alzheimer's, you have frontotemporal. It doesn't add anything to them because it's not going to stick and they're not going to have the ability to see that they have it. The diagnosis, especially once you get past that early stage, is really for the people who provide care for that person living with dementia. We need a name for it so that we can make a plan and maybe discuss treatments if that's appropriate for that type of illness. Again, this is part of that not telling the whole truth or that therapeutic lying or fibbing. It is okay to go to the doctor with somebody that you're providing care for or a loved one and slip a note to the doctor or the nurse practitioner ahead of the visit with all of your concerns and take it out of your hands as to whether or not that person is going to get a workup in regards to dementia. So it is completely fine for you not to be involved. And actually, I know you're going to talk about driving at another time, but again, that's another one. It's perfectly fine for you not to be involved in the driving conversation. Let the doctor, the nurse practitioner, the physical therapist be the one. But that's one of those times where it is okay to kind of work behind the scenes. It is worthwhile to get a diagnosis because you need to plan. I mean, there's medications out there that slow down progression, but more importantly, you need to plan for health, safety, future, finances, all of those things.
The argument just quickly about that you can't win an argument with somebody with dementia. Somebody said, is it worth it, to argue about it? How would you respond to that?
Only if health or safety is an issue. Otherwise, there's no need to argue whatsoever. It's just going to make everybody feel bad. It's going to make everybody's blood pressure go through the roof, and you're going to increase the risk of agitation and aggression, maybe wandering, all of that.
Thank you. These two questions are about the caregiver conferences. Everyone, I'll send you all the links to the conferences in emails after this. But thanks for asking. Next question, when removing clutter in mild stages with specifically hoarder-like habits, how do you do that without distressing the elder? I think you might have addressed that earlier. I hope that that was enough earlier. Okay, if caregiver is not acknowledging need for medical care, increases risk for health decline, would this be considered as neglect and reportable to APS?
This is that whole conversation. If that's a difficult question because that's a very individual type situation. Because, like I was saying, with the patients who don't want to come see me, but I reach out to the families regularly, or I do a telehealth regularly, and maybe I see them for just a few minutes. Um, if everybody understands, and that includes the person who's making decisions for the person living with dementia. So let's say we have a son who's the medical power of attorney for the mother who's living with dementia. If that son understands the risks and benefits of everything that is going on or not going on, and we've had a conversation about it, and everybody has accepted the situation as it is, that's not neglect. If we make suggestions about things that are imminently unsafe and they are ignoring it and not doing it, that's neglect. But it's a very individual question. And Ivy, you probably have some 2 cents about that as well, because that is a question that families worry about. Is this neglect, or heaven forbid, is this abuse?
Right, yeah, I think that's well said.
Hey, um, yeah, the PowerPoint, I'll be sending the PowerPoint to everyone, or the link to the PowerPoint. And also a person asked about the meaningful activities. I'll send the link. We do have previously recorded sessions that I can send you that there was about activities that Dorothy Colby, who has been helping us on this webinar, and
Can
as a
I?
rocks. Yes,
Oh,
go
sorry.
ahead. Go ahead.
Oh, I was going to say, can I just take 1 second to plug daycares and day healths when you're talking about activities? Because somebody who has anything more than usually about a mild stage of dementia isn't going to have self-motivation to do activities. So if somebody is sitting in a room with puzzles or crochet or, simple woodworking or anything like that, they may not actually have the self-motivation to start that. So either somebody in the house is going to have to motivate that person to do those activities, or there's wonderful places, adult daycares and adult day healths, where you send an elder. They have structured days with activities and exercises and meals, and they hydrate people, which is so incredibly important. And it's probably the best treatment for apathy and frailty and dehydration and dementia in general. And it's just an absolute wonderful resource to make sure that somebody is both safe and supervised as well as stimulated.
There's a question about the online. There is going to be an online link, as Ivy mentioned, for the March 27th seminar. I'll be sending that flyer to everyone so that you know when to register. And the recording and the transcript you can get, I will send that to everyone, those questions afterwards. Just a comment, I heard something about early detection being important. This seems to be a tough thing to get formal confirmation of this disease from an MD when the family already knows it's true.
There's not enough of us to go around. So most people who, and most families are right. Most families have an idea. If somebody has dementia, they probably really do have dementia. Not always, but most of the time. We have a shortage of geriatricians. There was that fabulous article in the paper yesterday, in case you want to know just how dire it is when it comes to geriatric care, both physicians and nurses and everything down to day-to-day hands-on care. So there's just not enough. But getting a referral to a geriatrician or a neurologist or maybe a geriatric psychiatrist from your primary care is the best way to get that diagnosis. There's a few people out there, especially young onset, who may actually want to have very definitive diagnosis, so have specialized scans or specialized lab tests to really prove that they have the brain protein changes associated with Alzheimer's disease. Um, but most people come and see a geriatrician or a neurologist and have testing done and brain imaging and labs and memory testing and all of that to get a formal diagnosis. But yeah, there's we have a wait. You like I said, there's a wonderful article, very timely in the paper that talked about the wait to see geriatricians.
Somebody's asking about conferences on the Big Island, but Ivy, isn't one of them going to be on the Big Island?
You
Let me
know,
know.
the caregiver conference will be on Kauai, but we do have some other sort of mini conferences and events for caregivers on the Big Island. So folks can check out our website, alz.org/Hawaii, and that will list everything that's upcoming in terms of programs on all of the islands. You can always call us as well, and we can help make sure we plug you into the right program on the right island.
Thank you. How do you handle when a person is afraid of someone at their care home? Say that the scary person has an evil spirit.
Um, I'm a real believer in your gut instinct in situations like that. And if somebody's gut says that this is not ever going to be a good fit, then you probably need to consider moving that person to another living situation. Um, One of my patients lives in a care home and doesn't allow the patient's, or I'm sorry, doesn't allow the caregiver's husband to provide hands-on care, but that's more of a male-female type situation. And the caregiver is very understanding and she provides all the personal care. And then the husband does, the non-bathing and toileting and all of that. But if something in your gut says this isn't right, I think you got to listen to that.
Okay. I cannot get my 98-year-old mother-in-law to take a shower. It has been months. She does not smell, but I know this is not good. She always claims she just took one. I'm hoping, Diane, you can put the link in the chat for showering without, what is it? The link, everybody, shower without an argument, or there's a specific website on how to deal with people that won't take a shower. We'll find it. One of
I
us will find it.
was gonna say, Ivy, I don't know if you want to take this or I've been talking a lot.
Well, no, I had kind of a funny and personal sort of anecdote. My grandmother had vascular dementia, so we, helped take care of her at home. And shower was an issue. She did not like just the way the water would come down on her. So the physical sensation of a shower was very uncomfortable. She's, old school Japanese. So after a lot of trial and error, we found that she would take more like a bath. So, to kind of replicate how she would bathe when she was young, she would kind of squat and use a tarai, which is basically like a little scooper. And if we washed her that way, she loved it. She did not like the shower, but that kind of modification was something that she was okay with. Um, so maybe trying, different, using different equipment, different setup for bath, shower, might be worth trying.